So welcome you all to our current session on INICET important questions and anticipation of what have been or what can be asked in future examinations, right? So knowing important questions of previous year is very important as a strategy for you all for your coming NeetPg examination. Right? So today we intend to do the same. I am Dr. Shivam, a resident in ENT head neck surgery, and here to help you all in your journey through NeetPG. So I started my teaching journey with the only aim to help you all in this tough phase of transition, and this year it has been extra tough for you all, right? The exams kept on postponing, the COVID time was tough, but still, if you are here, if you are watching it live, and still, if you have continued your journey, I hope you will end it in a grand manner, right? So don't lose hope. You still have time with you, right? So you still can do it, and so till some people join, we will just discuss some of the thing that is recently your INICET results have been out, right? So many of you are disheartened. Today also they gave things about some reservation and all. So don't think that things are very negative. Try to find the positive thing in whatever is happening in your life, right? So just observe the life cycle of a butterfly. What happens with the butterfly? When the butterfly is in caterpillar stage, like you all are in your caterpillar stage. You are yet to develop into a butterfly, right? So when the caterpillar thinks that his or her word is going to end, it gets transformed into a beautiful butterfly like this, right? So there is no end. वो बोलते हैं ना कि अगर एंड अच्छा नहीं है इसका मतलब पिक्चर आपकी अभी बाकी है, राइट? सो देयर इज अ great quote by Shahrukh Khan also. So if the things are not going good, just start doing whatever is there, whatever you can do at your first hand. So start doing what is necessary at present. That means start revising little and then do what's possible. Try to extend yourself and do whatever possible you can do in a day, and suddenly you will realize that you are doing impossible things. So this is the key, right? Start doing whatever is there with whatever you have read, start revising it. Whatever you think is weak for you, you are forgetting, start reading them. Whatever notes you have here, there, near you, just pick it up and read it, right? So start doing what is necessary and then what is possible, and finally you will see that you will be doing impossible things. You will realize how much you have attained over the time. Now, very different question this time in INICET, which I think not many people have discussed, right? So this was the question. If you see this question, they had asked about CMV and sensory neural hearing loss. So although we all know that congenital CMV infection is important, but this time in the options, they had asked little different things. What they had asked is the percentage of congenital CMV infection causing sensory neural hearing loss. So if you read the option, a CMV is estimated to cause 20 to 30% congenital SNHL. CMV symptoms presents at birth. Treatment can be started after 6 months. Some patients may remain asymptomatic, may show symptoms after the birth. Now to answer this, you should know something about CMV and its infection. So the first, that is, yes, there are chances of 20 to 30% of baby having SNHL with congenital CMV infection. And what is CMV? CMV is a double-stranded DNA virus of human herpes family, right? The incubation period is 7 to 12 weeks. So you can note them down because these can be your future questions. How you will identify what is the symptomology of CMV? The baby will be small size for gestational age. He or she will have microcephaly, jaundice at birth, hepatosplenomegaly, petechiae, hemolytic anemia, pneumonia, chorioretinitis, sensory neural hearing loss, lethargy, poor sucking and seizures, right? So again, if you see the symptomology, hepatosplenomegaly, jaundice, microcephaly, chorioretinitis, right? So these are very important symptomology of congenital CMV. What else you can see here? You can see here a congenital CMV case and you can observe periventricular calcifications, right? So these are also a symptomology of the congenital CMV. What you will get? Periventricular calcifications. So these can be your future questions, future NeetPG questions, because they had asked about congenital CMV. So you should know everything important, and that is the intent of today's discussion. Not to just rush through the question, but know everything. So this is the fruitful discussion that should happen rather than only knowing the question. You should know the topic rather than only knowing the question, right? This is a picture showing chorioretinitis seen in congenital CMV. And one very important thing that you should know about congenital CMV is in CMV infection you get owl's eye appearance, right? You all know this. You get owl's eye appearance. One more condition where you get owl's eye appearance is your Hodgkin's lymphoma, right? And you need to differentiate your Hodgkin's lymphoma owl's eye from CMV. Here again, if you see, this is your CMV showing owl's eye appearance like this. Now in Hodgkin also, like you see, the first image is of CMV and second is of Hodgkin. Now what is the difference? I'll tell you how you can differentiate owl's eye appearance of CMV from Hodgkin. Now if you see, if this is your Hodgkin and this is your CMV, right? So what is the difference? In Hodgkin what you get is, you get nuclei, you get eosinophilic nuclei. So these pinkish things are eosinophilic nuclei, or you can say nucleoli, right? Inside the nucleus, these are nucleoli. In CMV, what you will get, the things that you get as owl eye are your inclusion bodies, right? So if this is CMV, this is Hodgkin. So you should know, because this is something which is coming between the pathology and both. So nowadays the questions are related. So they can ask you, and you should know by seeing the histopathology. I'll tell you how you can differentiate between the Hodgkin and CMV owl's eye. So that is the whole purpose. In CMV you will get the inclusion bodies. The eyes are the inclusion bodies, right? These are inclusion bodies. Eyes are the inclusion bodies in CMV, and these inclusion bodies are basophilic, bluish basophilic, and here the eyes are your nucleoli, right? Inside the nucleus there is nucleoli. So this eosinophilic nuclei looks like owl eye in Hodgkin. In CMV these are basophilic inclusion bodies, right? And what else, how else you can identify? You will observe more inclusion bodies in the cytoplasm also. Like if you see here, you will observe this inclusion bodies here along with more inclusion bodies in the cytoplasm. How and what else you can see is there will be a perinuclear halo, like you can see here, right? So between the inclusion bodies and the nucleus, there will be a perinuclear halo in CMV. Like if you see this diagram, here also you will observe, here also if you see, you will observe this is your inclusion bodies inside the nucleus, and this is your perinuclear halo, which will not be seen in the Hodgkin. So there is a perinuclear halo in the CMV. And if you see your Reed-Sternberg cell, these are the eosinophilic stained nuclei. There is no perinuclear halo. This is your nucleus, and this is your nucleus, and this is your nuclei, stained eosinophilic stained nuclei, right? But in case of CMV, if you see, you will get nucleus, inclusion bodies, and a perinuclear halo like this. So this will be your CMV. The PPT I'll give you in the Telegram group or the WhatsApp group if you are there. If not, I'll put the link so you can get the PDF so as to revise it. Now, how you are going to diagnose this CMV? So there are methods to extract CMV virus from urine and other body fluids like CSF, blood, saliva in first 21 days of the infection, of the congenital infection. There are some serological tests also like IgM and IgG which are available, but they have false positive and false negative report. PCR is definitely a very confirmatory test and may be useful in selected cases. Now, if you are given this IgG and IgM, how you can interpret whether the baby has infection or not? So, interpretation of neonatal CMV antibody is important, and that is we are going to discuss now. So if the IgG in the baby is positive and IgM is also positive, that means the baby is having congenital infection. If IgG is positive but IgM is negative, that means baby is having maternal antibodies. If IgG is negative but IgM is positive, this means there is a recent infection. So you always know if IgM, it is the recent or acute infection, right? So very clear, if IgG is positive, IgM is negative, that means these are the maternal antibody got from the mother. If IgM is positive, that means a recent infection, and then you need to treat the child, right? Then you need to treat the child. If the symptoms are present, more than two symptoms are present and IgM is also present, then you need to treat the child. And what drugs are there? So in future you might get a question for the first line drug, that is ganciclovir and valganciclovir, right? So these are the two first line drug. If the baby is having toxicity from them, then you can move to the second line or the alternative, which is foscarnet and cidofovir, right? So remember ganciclovir and valganciclovir, right? So as soon as you detect these congenital, you can start the treatment with these drugs. Now coming to very important question and very predictable, you can see, which have been asked this INICET July. Now read this question. A 60-year-old male with complaints of bilateral hearing loss and occasional episodes of vertigo shows a histopathology slide like this. Now what can it be? Vestibular schwannoma, meningioma, epidermoid cyst and glioblastoma. So if you observe, your Aiims or INICET have a regular trend of asking this topic basically, which is your vestibular schwannoma. They can ask you this in numerous number of ways. This time they had asked about Antony A and Antony B areas, right? So you all know they already asked this question, Antony A and Antony B, and what are these? These are basically your crowded and less crowded areas in the histopathology slides of vestibular schwannoma. So if you see this Antony A area, it will be composed of densely packed cell with small spindle shaped nuclei, right? So what कैसे आप समझेंगे? In Antony A there will be densely packed cell. In Antony B it will be loosely arranged vacuolated cells. Or in antennae A, these densely packed cell contains nuclei which are called Verose bodies. So if you see this, here we have given the description that antennae A is closely packed cell with spindle shaped and densely stained nuclei that is called Verose bodies. So Verose bodies are seen in antennae A pattern, and antennae B pattern is loose cellular aggregation of vacuolated pleomorphic cell. So अगर हम ये histopathology slide पे again जाएं तो antennae A will be your denser part, right? And like this one. So antennae A is your denser part. This part is your antennae A area, and less denser part is your antennae B area, right? So it's very easy to identify, as they have given this time antennae A and antennae B. Next time they can ask you questions from vestibular schwannoma. So that is why we can discuss few important questions from the vestibular schwannoma that can be asked in your future NeetPg, right? So vestibular schwannoma, you all know it is a cerebellopontine angle tumor. The sign that you can see here on the radiology is ice cream cone appearance, right? So this appearance is called ice cream cone appearance. Ice cream cone appearance. You all know this cerebellopontine angle tumor, that is the showing you ice cream cone appearance. And what is very important for this tumor is this is the most common, you can say, or 80% of all the cerebellopontine angle tumor, right? So 80% of all the cerebellopontine tumors are vestibular schwannoma. It is benign, encapsulated, slow growing, you can say extremely slow growing, and locally invasive tumor, right? And what else you should see is again the location of this tumor, which that is why it is called cerebellopontine, because here you can see your pons, here you can see your cerebellum, and between this cerebellum and pons your tumor is located, which is called vestibular schwannoma. Now some important questions that are related to it are here. So most common site, if they ask, is your inferior vestibular nerve. If inferior vestibular nerve is not given, then you would go for superior vestibular nerve. So I had already made a video separately for vestibular schwannoma. Here I will discuss only the small and the high yield tips or points from this topic. The link I'll provide you in the group. You can watch it in your spare time. So most important questions are: inferior vestibular schwannoma is the most common site. Again, in future, what they can ask is about neurofibromatosis too. Why? Because this time they said bilateral sensory neural hearing loss. So if you observe, your vestibular schwannoma is a unilateral tumor. Mostly it is unilateral, but if it is bilateral, then you should suspect neurofibromatosis too, right? So bilateral vestibular schwannoma is diagnostic of neurofibromatosis 2, is one of the diagnostic criteria of neurofibromatosis 2. And you know this neurofibromatosis thing is very important with regard to your exams like NeetPg and INICET. It originates from the Schwann cells of inferior or superior vestibular nerve at a very important zone called Obsteiner Redlich zone. What is it called? Obsteiner Redlich zone, which lies in the peripheral myelin. The gene that is responsible is Merlin, right? So it occurs due to mutation in a gene located on chromosome 22q12. Clinical features पे आते हैं, right? So थोड़ा सा discuss करेंगे very fast. The age, the most common age group is 40 to 60 years, and when it is seen bilaterally associated with neurofibromatosis, it is seen in relatively younger population, that is in 20 to 30 years. Both sexes are affected equally, and 90% of cases are unilateral, bilateral in NF2. So अगर हम अपने क्वेश्चन को देखें, उसमें बोला था 60-year-old male, right? So 60-year-old male का मतलब है कि most common age is around 40 to 60 year, and sex का कोई importance नहीं था because it is seen in both the sexes equally. 90% cases are unilateral. Bilateral, you should suspect a neurofibromatosis too. Now the thing is, how the tumor progresses is responsible for how the patient presents to you. Means at what stage. As the tumor grows, it involves more cranial nerves and thus you will get more symptoms. Like if you see this tumor arises from the vestibular nerves, which is located in the internal acoustic meatus or the internal auditory canal. Now, as the tumor grows, it reaches the cerebellopontine angle, eroding and widening the internal auditory canal. So, जैसे जैसे tumor बढ़ रहा है, जैसे जैसे cone से tumor बढ़ रहा है, it is becoming like a ice cream, right? So, जैसे जैसे बढ़ेगा, it will keep on pressing along the nerves, the cranial nerves, and you will get symptom like अगर ऊपर की तरफ जा रहा है, so it will involve cranial nerve 5, which will give you the earliest sign for vestibular schwannoma, right? I will discuss it in the next slide. So earliest sign you will get due to involvement of cranial nerve 5. अगर नीचे की तरफ grow कर रहा है, then it will involve cranial nerve 9, 10 and 11, which lie in the jugular foramen. So the growth of this tumor is important because then you will know how advanced the tumor is, right? And if it is very big, it can displace the brainstem and put pressure on the cerebellum, causing raised intracranial tension and more severe disease. Now, as we were discussing about the earliest sign, we should know about the earliest symptom. So, earliest sign that you will get with the cranial nerve 5 involvement is your decreased sensation of the cornea. So, corneal sensitivity, corneal sensations will decrease due to this cranial nerve 5 involvement. And what should be the earliest symptom? As it is a tube of vestibular nerve, a cochleovestibular symptoms would be the most common or the earliest. So as the tumor is arising from the internal auditory canal, the patient will present with earliest symptom would be deafness, that is sensorineural deafness and tinnitus. So कैसा sensorineural deafness होगा? It will be progressive. क्यों बढ़ रहा है? Because the tumor is also growing. So it will be progressive, unilateral SNHL, right? Presents in 95%. Often accompanied by tinnitus, which is only present in 65% of cases. Now, एक और चीज, how you can identify कि whether this sensory neural hearing loss is associated with this or not. There would be marked difficulty in understanding speech out of proportion to the pure tone hearing loss. So जितना भी hearing loss होगा, उससे ज़्यादा आपको लगेगा कि patient को सुनने में दिक्कत है, because patient will not be able to apprehend the speech. So there will be marked difficulty in understanding speech, right? So mark this, in understanding speech, patient would be having lot more difficulties. And as we already discussed, as it grows, it will involve different cranial nerves. Like fifth को involve किया तो क्या मिलेगा? Reduced corneal sensitivity, right? और क्या मिल सकता है? Paresthesia. इस साइड, जिस भी साइड का है उस साइड का फेस का सेंसेशन कम हो सकता है due to involvement of trigeminal nerve, this fifth cranial nerve, and this will give to the earliest sign. जैसे जैसे बढ़ेगा cranial nerve 7 को involve करेगा, cranial nerve 9, 10 को involve करेगा, तो 9, 10 से क्या होगा? Dysphagia होगा, patient को glossopharyngeal nerve है. 10 से क्या होगा? Hoarseness होगा, because vagus का branch होता है recurrent laryngeal nerve and superior laryngeal nerve, right? और palatal pharyngeal laryngeal palsy. फेशियल नर्व से क्या होगा? फेशियल नर्व के इन्वॉल्वमेंट से यू विल गेट वन मोर साइन. एनीबडी ऑफ यू कैन टेल मी व्हाट इज दिस साइन? यू कैन कमेंट मी. So facial nerve involvement will result into a sign called Hitselberger sign, which is hypostasia of the posterior meatal wall. So very important sign. Hypostasia of posterior meatal wall. When you will touch the posterior meatal wall, you will see that the patient is not having any sensation, and that is called Hitselberger sign. Right? Hitselberger sign. Numbness of the posterior meatal wall is the Hitselberger sign. Now finally summarizing the most common ones from vestibular schwannoma for your Neetpg is: most common nerve, inferior vestibular nerve. Earliest symptom, progressive unilateral SNHL. Earliest cranial nerve, the sequence is eighth nerve, because it is a tumor of eighth nerve, vestibulocochlear nerve, followed by fifth nerve and followed by seventh nerve. Fifth nerve will give you reduced corneal sensitivity, seventh nerve will give you Hitz-Berger sign, and eighth nerve will give you progressive unilateral SNHL. Earliest presentation of the fifth nerve, we all know it is reduced corneal sensitivity. And one more important question, if the fifth nerve is involved, that means your tumor is at least 2.5 centimeter in size. Earliest presentation of seventh nerve is your Hitz-Berger sign. Now finally, you know most common, that is 80% is your vestibular schwannoma. But what others are your CP angle tumors? So you should know that 10% is your most common, means second most common after a vestibular schwannoma is meningioma. Some might constitute congenital cholesteatoma and then others. So 80% vestibular schwannoma, 10% meningioma, and then rest are others. Some cholesteatoma 5% around. Now this was a very easy question they had asked because they are going into clinical things, so they are focusing more on the pictures like this. So a 10-year-old boy at OPD presenting to you with the following facial features. So what all you can see is the high arch palate, crowded tooth, and pinched nose. So the options were frog face, bird-like face, and your adenoid faces. So what you all think? Yes, this is your adenoid faces. Now, adenoid faces, you will get symptoms like this, where the child will be showing with this type of face, having sunken eyes, narrow pinched nostrils, open mouth, high arch palate, crowded teeth, protruding teeth, drooling saliva, and loss of nasolabial folds. Right? Why these all are happening? Basically, the nasal respiration, the nasal breathing is closed by the presence of adenoid, hypertrophied adenoid. So what is happening? This nasal part is becoming less used. So there is there is atrophy, you can say, of these ala of the nose, that will result in narrow pinched nostril. What else this adenoid will cause? This adenoid will block the eustachian tube, right? So adenoids will block the eustachian tube, that will result in otitis media with effusion, and this otitis media in effusion will be the cause of conductive hearing loss, right? So conductive patient, अगर बच्चा सुन ही नहीं पा रहा है, so how you will learn? So बच्चा कैसा बनेगा? लगेगा कि idiotic है, उसका IQ कम है, because patient is or baby is not able to hear because of otitis media with effusion caused due to blockage of eustachian tube. High arch palate because of mouth breathing. Patient is taking air through mouth. So these are the adenoid faces features. Flat, expressionless face due to loss of nasolabial fold, open mouth, dry lipped. You all know this. Now what is this frog face? So frog face is basically seen in your JNAs or angiofibromas. So if you see, this is the look that you will get in JNAs. JNAs, right? So peculiar age with JNA is your 14-year male. Why 14-year male? Because it is a testosterone dependent tumor. So people say that this is a testosterone dependent tumor. So this 14-year male, that is young male, you should have in your mind the diagnosis of JNA, which is very vascular. Why we fear this? Because it bleeds on touch. So biopsy is contraindicated in JNAs. It bleeds on touch. Investigation of choice is CECT. You will get a CECT scan done to see the JNA, and what you will observe? You will observe the tumor growing in the pterygopalatine fossa. Pterygopalatine fossa, tumor arising from pterygopalatine fossa. And why we fear it? Because it bleeds, and that is why biopsy is contraindication. Now if I ask you why it bleeds, anybody of you can tell me? Because there is the vascular, the endothelial structure is not formed. That means the vascular basement membrane is not there, so it will bleed. The vessels will not be able to contract on injury. Okay, so if you injure it, if you take a biopsy, it will keep on bleeding. So frog face will be seen in JNA. This is another face which they can ask you in future is allergic faces, like in seen in allergic patients. So you will observe this Denny Morgan lines, allergic shiners, nasal crease over the nose, dorsum like this. So remember, this will show you that the patient is having allergic rhinitis or something. So Dennis Morgan line, allergic sinus is another phase. And these are other phases that you can read it. I'll provide the PPT and we'll move to another important question that they asked related to COVID, right? So they said intracranial complication in COVID is due to spread of which of the following. I don't know whether they had marked this area or not, but you should know that this area that is marked here and the question that they are saying, the answer belongs to cribriform plate, right? So this, the area that is marked here is cribriform plate through which the COVID virus, right, might enter into intracranial cavity. Now there are three postulates or theory which you can say or which you should remember regarding this COVID-19 infection. One is the virus might enter into the cranial intracranial cavity by piercing the blood-brain barrier, right? Second is via olfactory nerve. So this time they had asked about cribriform plate through the olfactory nerves, right? Via olfactory nerves, they will enter into this cribriform. Through the cribriform plate, they will enter into the intracranial cavity. And third is by the involvement of the peripheral nerve fibers. Peripheral nerve fibers. So for future, you should remember that intracranially this COVID-19 might progress through these three possible ways. And one more is, if in the post-COVID or COVID phase patient gets a fungal infection like mucormycosis, so mucormycosis is very prone to cause rhinocerebral mucormycosis, where this sinus fungal infection might erode these bone and enter into the intracranial cavity. So that is called rhinocerebral mucormycosis. But that is a different entity. I just told you here because this is also something which is very important for your future NeetPg examination. Rhinocerebral mucormycosis. Right. Again, here you can see your cribriform plate. Right. This is your cribriform plate, which is a part of ethmoid bone. Here you can see cristagalli. Now in a CT scan, you should be able to identify which one is your cribriform plate. So if you see here, this part is your cribriform plate, and this cribriform plate is made up of two parts. This is your lateral lamina. This is your medial lamina. How it looks like this. Like here in center you have cristagalli. So this is your lateral lamina. This is your horizontal lamina. Okay. We also say vertical and horizontal lamina, and at this junction is the most common site of CSF leak, right? CSF leak called crista ethmoidalis. क्या बोलते हैं इसको? Crista ethmoidalis. Sorry, fovea ethmoidalis, right? Fovea ethmoidalis. So this cribriform plate is so thin that it forms the most common site of CSF leak at the junction of lateral and medial lamella of the cribriform plate. This is your cristagalli. This is your cribriform plate. So they can give an arrow over the cribriform plate and they can ask you what is it. Now, very interesting question. I think most of you have made wrong is marked area is operated. What will be the most common cause of bleeding after tonsillectomy? So if you see, they had marked a tonsillectomy site. Some students have also told that there was a cotton soaked in blood placed over the tonsillar region post tonsillectomy, and they had asked what can be the most common cause of bleeding, whether it is a tonsillar branch of facial artery or paratonsillar vein. Now just to revise for you the tonsillar blood supply, because you should know this very basic. So this figure shows you the tonsillar blood supply. First is your dorsal lingual artery, right? So this is your dorsal lingual artery, which is a branch of lingual artery. Second is your ascending palatine artery, right? So this is your ascending palatine artery, branch of your facial artery. Then one more branch of facial artery is your tonsillar branch of facial artery. So one is your ascending palatine artery, branch of facial artery, and another is your tonsillar branch, ascending palatine and tonsillar branch of facial artery. Then ascending pharyngeal artery, which is a branch of ascending pharyngeal artery, which is a branch of external carotid artery, ascending pharyngeal. So दो चीज ascending palatine, ascending pharyngeal, tonsillar branch, lingual branch, and finally the lesser palatine artery, which is a branch of maxillary artery. So this is the arterial supply. Now, do you think that the bleeding that occurs post-operatively, that mild oozing that keeps on occurring, or the most common site after this tonsillectomy bleeding is tonsillar branch? No. This is your paratonsillar vein, right? So tonsillar venous drainage is by the peritonsillar plexus. So if you see, this is your tonsillar branch of facial artery and this is your paratonsillar vein. So the most common cause of bleeding after tonsillectomy is your paratonsillar vein, this vein, right? So here the answer would be your paratonsillar vein. So don't confuse, guys. The answer is paratonsillar vein. Tonsillar artery you won't leave, because if you are doing a tonsillectomy and this artery is bleeding, it will be oozing like anything. It will be like flushing whole of the site and you can't leave it, right? You have to ligate that artery. But these veins, they might keep on oozing some blood which is there in the cotton. So the most common cause is bleeding from the paratonsillar vein. Here also again you can see your paratonsillar vein in the paratonsillar space. Now, very interesting question they had asked about CT scan of nose and paranasal sinuses. So I have already told you how important it is to know the CT scans of nose and paranasal sinus. What they had asked is, they had marked an area in the CT scan and they had asked whether it is anterior ethmoidal cell, posterior ethmoidal cell, cibriform plate, or what else. So already we had discussed it in our class that the anterior ethmoidal air cells are divided from the posterior ethmoidal air cells by a structure that is called basal lamella, right? Basal lamella or ground lamella. So what is this basal lamella or ground lamella? This basal lamella or ground lamella is a part of middle turbinate. So if you remember, your middle turbinate had three parts, right? Which we had remembered by a mnemonic called SCH, sagittal, coronal, and horizontal, right? So middle turbinate is like this, sagittal, then it moves like this, coronal, and then it becomes horizontal. So sagittal is attached to the cibriform plate, horizontal is attached to the lateral wall, that is your lamina papyracea, and the horizontal is to the palatine bone. So sagittal, coronal, and horizontal. So this coronal part is called ground lamella or the basal lamella. So if you insert the endoscope, you will see the sagittal part of the middle turbinate. Then if you remove the bulla, you will see the coronal part, that is your ground lamella, which is separating the anterior, whichever cells of ethmoid is anterior to the basal lamella is your anterior ethmoidal cell. इसके पीछे जो होगा, whichever is posterior is your posterior ethmoidal cell. So if this is your nose, like from here you are inserting endoscope. So if you are inserting endoscope and this middle turbinate is curving like this, so whatever will be here is your anterior ethmoidal cell, whatever here will be posterior ethmoidal cell, and this is your basal lamella, right? So if you see more here, you can see this is your, so iske aage is anterior, iske piche is posterior. Again, if you see in this, which is a sagittal cut, if you see, this is your anterior ethmoidal cell, these are your posterior ethmoidal cell, and the middle is your basal lamella. You see basal lamella, right? So basal lamella is separating the anterior from the posterior. और एक चीज क्या याद कर सकते हैं? Anterior ethmoidal air cells are more in number and smaller in size, right? So अगर आप देखो anterior ethmoidal cells are small and they are more in number, while posterior ethmoidal ear cells are less in number and bigger in size. So just to make you know the differences I told you, again here you can see your anterior and posterior, and one important thing that they had asked in one of your previous year exam is this agonized cell. So agonized cell might be present, might not be present. Actually, if it is pneumatized, then you would be able to see it. So what is this? This is the most anterior ethmoid air cell. And what is the most constant? Most constant, anybody? Most constant anterior ethmoidal cell? Most constant anterior ethmoidal cell is your bulla ethmoidalis, right? But most anterior is your agonized, right? This agonized cell is there in relation with the facial recess. क्या होता है कि अगर agonized pneumatized है, बहुत बड़ा है, तो ये frontal, not facial, frontal recess. So ये frontal recess को narrow कर देता है. So to open the frontal sinus, you have to remove this agonized. Just this is something extra which I wanted to tell you, that agonized is related to frontal sinus. Okay, so this agonized is related to frontal sinus, and this is something which you should know. Now some anterior ethmoidal air cells are like this, halar cell, right? So this is a halar cell which is seen in the orbital floor. Okay, so excuse me for a sec. I just went for something important. So we were talking about halar cell. Any cell which is related with the orbital floor is another variation of ethmoidal air cell, that is called halar cell. So just remember, orbital floor, if it is related, this is halar cell, and if it is related to the optic nerve, it will be Onidi cell. So these two cells are again important for your coming NeetPg. That's why I discussed. If it is related to optic nerve, it will be Onidi cell. If it is related to orbital floor, so this is your orbit, right? And if you see, this is your orbital floor. This is your maxillary sinus. So what is the importance of halar cell? Halar cell is closing the drainage of maxillary sinus. That is why it is important to open this halar cell and maintain the maxillary sinus drainage. This is your maxillary sinus, right? So this is your maxillary sinus. So halar cell. Now how Onidi cell will look like? Onidi cell is related to optic nerve. कैसे याद करोगे? Onidi and optic nerve. O for O, right? Onidi for O. Onidi and optic nerve. Onidi cell कहाँ होता है? Halar cell तो orbital floor पे था. Onidi cell कहाँ होता है? Which is related to the optic nerve. Onidi cell रहता है sphenoid sinus के relation में. कहाँ? Sphenoid sinus के posterior superiorly. So अगर ये sphenoid sinus है CT scan में, so this is your Onidi cell. अगर ये sphenoid sinus है, so this is your Onidi cell, right? और सबसे easy होता है Onidi cell को identify करना is अगर if and if there is any horizontal septation in the sphenoid sinus. So अगर ये तुम्हारा sphenoid sinus है, मानो, like if this is your sphenoid sinus, so if there is any horizontal septation like this, then you would say that your Onidi cell is present. This vertical septation is always there. This is intersphenoidal septum. But if there is any horizontal septation like this, you will say that Onidi cell is there. And why it is important to know Onidi cell? Onidi cell का importance क्या है? Because ये optic nerve से related है, right? Optic nerve से relation का मतलब, if you are doing functional endoscopic sinus surgery and if you by mistake injure this optic nerve, you will be sued medico-legally. They can sue you medico-legally. So you have to prevent optic nerve injury. That is why you have to know whether Onidi cell is present or not. Here also, if you see, this is your Onidi cell that is there. This is your Onidi cell that is there in relation to the optic nerve. This is your sphenoid sinus. Now, एक और क्वेश्चन जान लो sphenoid sinus के रिलेशन में जो पूछा गया था, that is your median canal and foramen rotundum. So again this is your sphenoid sinus, right? ये आपका sphenoid sinus है, यहाँ पे आपका optic canal है, यहाँ पे आपका carotid artery का bulge है, internal carotid artery का, और नीचे अगर फ्लोर पे देखो so you will observe two holes like this. So जो बाहर की तरफ होगा laterally will be median canal और जो अंदर की तरफ होगा will be foramen rotundum. So if this is your sphenoid sinus, जो outer की side होगा will be your median canal and here will be your foramen rotundum, right? So this image has been taught and already asked in your one of the exam. एक question जो कि already we had discussed in the WhatsApp group was with the Bent and Kunz criteria. So which of the following is not a criteria of AFRS according to Bent and Kunz criteria? So पढ़ते हैं क्या बोल रहा है. Allergic mucin, sinonasal polyp, fungal culture and CTPNS heterogeneous opacity, right? So अगर आपको याद है कि बेंट एंड कुन क्राइटेरिया क्या था, उसके अंदर दो चीजें आती थी. वन इज मेजर क्राइटेरिया, अनदर इज माइनर. सो इन मेजर यू हैड टाइप 1 hypersensitivity, nasal polyposis, characteristic CT finding, eosinophilic mucin without invasion and positive fungal stain, right? Mind it, positive fungal stain. Now again revise it. Type 1 hypersensitivity, nasal polyposis, characteristic CT finding, that is heterogeneous double density, right? Double density, heterogeneous opacity and eosinophilic mucin with positive fungal stain. And in question में देखे, allergic mucin yes, polyp yes, heterogeneous opacity yes, but just see how they are confusing it. Here they had mentioned fungal culture and not stain, right? Fungal culture and not stain. All of these are the major criteria except fungal culture. Why? Because fungal culture is a criteria, but if you observe, it is minor criteria, right? So Charcot Leiden crystal, serum eosinophilia, fungal culture, bone erosion, asthma, these are minor criteria. But among the major criteria, if you have to see, there is fungal stain and not culture. So the answer becomes here fungal culture, which is not a criteria or major criteria for AFRS. So here this CT has been given to let you know the double density sign. This is the more contrast enhanced part and this is the less. So this is double density, two densities you can see here, right? And this one is to show you how the allergic mucin looks like. So this is also one of the major diagnostic criteria. This yellowish sticky thing is your allergic mucin and here is your heterogeneous double density sign. And this question was something which was asked previously but still people have done wrong. They have asked you what type of block is being given here. So this is a type of block that you say as dorsal nasal nerve block. So if you observe, what we do here is we block the external branch of anterior ethmoidal nerve or the nasociliary nerve. We block the external branch of anterior ethmoidal nerve or the nasociliary nerve. So what it does, it is supplying the lateral nasal wall, ala, vestibule, tip, anterior septum. When we do these type of nerve blocks, we do it in the rhinoplasty surgery. कब करते हैं? जब हमको rhinoplasty करना होता है. So see here how they are blocking the anterior ethmoidal nerve. So I don't know whether this same picture was there or not, but I will tell you how you can identify for your future examination ki which type of block is, for what nerve the block is given. So if the needle is here, that means you are blocking the external branch of anterior ethmoidal nerve or the nasociliary nerve, which according to the recall is the answer. But if you say that the needle was here, then it is infratrochlear nerve block. If the needle is above, then it is supratrochlear nerve block. If the needle is here, then it is infraorbital nerve block. So save this image in your memory to answer the future questions, right? Now very fast, only one or two questions more and then we will end the session. Again from COVID-19, and they said a post-discharge COVID-19 had a history of hospitalization in ICU, right? That means the patient became serious during his admission, was on oxygen support and steroids, right? So mind it that patient was on steroid. Whether patient was diabetic or not is not given. Which are the warning signs that you will be advising patient to look for in discharge phase? Nasal obstruction, anosmia, diplopia, RT-PCR positive. So this is something which we all should know, because COVID has become pandemic and we should know how to take care of our COVID patients. So what are the warning signs? So one of the warning signs that they intend to ask is for the black fungus. They need to see whether the patient is developing this black fungus or not. Why? Because this black fungus became epidemic, right? Epidemic in some states. What has happened is, for all the high risk patients who had a long ICU stay, who were diabetic, we suggested them to watch for some warning sign and to get the nasal endoscopy screening done to know whether they are developing mucormycosis or not. So what all you can see? You can see some eye signs like swollen eyes, redness around eyes and nose. You can see loss of facial sensation or facial pain, numbness, tingling. You can see you have to watch for fever, headache, and altered mental status, coughing, chest pain, bloody vomiting. So these are some of the important things that you would say your patient as a warning sign to watch for. Headache, numbness in face, nasal blockage with discharge tinged with blood, redness, pain around the eye, swelling of the eye, proptosis of the eye, drooping of the eye, double vision, very important. If it is like pushing the orbit, patient might complain of double vision, toothache, fatigue, fever, loss of consciousness, and others. Now, these all were the questions that they had in your INICET, and this ultimately what you need to realize is the main message is no subject is less important for you. This year from ENT, they had asked around 8 to 10 questions, and all of them were very, very important from all the important topics. So don't neglect any topic, right? Try to read the clinical subjects more intensively, give them little more time, but don't neglect any short subject, right? So the main funda for your coming NeetPG examination for whatever days you are left with is forget everything and revise whatever you have read. Revise if you have read notes, revise your notes, right? इन्हीं को भगवान बनाओ और इन्हीं को पढ़ो, इन्हीं की पूजा करो. अभी बहुत इधर उधर घूम के बहुत एमसीक्यू या नए नए उससे करके कोई फायदा नहीं है. नोट्स को रिवाइज करो और डिवाइड कर लो टाइम, लाइक डिवाइड योर टाइम इनटू 60-40 रेशियो. 60% में तुम नोट्स पढ़ोगे, रिवाइज करोगे, 40% टाइम में यू विल राइट सॉल्विंग एमसीक्यू, लॉट ऑफ एमसीक्यू, स्पेशली द प्रीवियस ईयर क्वेश्चन. प्रीवियस ईयर क्वेश्चंस से मेरा क्या मतलब है? व्हेन यू सॉल्व द प्रीवियस ईयर क्वेश्चन you will get to know the important topics and you will read it, right? So this exam, the main aim of this exam is to make you out of the game. So you have to try to be in the game by reading all the important topics that are being asked or can be asked in your examination, right? और कैसे पता चलेगा कि क्या पूछेंगे? पहले के क्वेश्चंस को देख के. So at least तुमको देखना क्या है कि बाकी लोग क्या कर रहे हैं. So बाकी लोग क्या कर रहे हैं? बाकी लोग जो पुराने पूछे हुए क्वेश्चन है उसको सही कर रहे हैं. So the other people are doing whatever have been asked, they are making them right. So you cannot afford to make those questions which have been asked wrong. That is why I discussed these questions which had been asked in INICET in detail and also anticipated some future questions, right? So by this I'll take my leave, wishing you all the very, very best for your coming NeetPG examination. From the core of my heart, I believe that you will be able to do it. Your NeetPG is just some hard 30-35 days after, and I wish that You will give whatever possible you can give from your side. Leave every tension, every this and that thought apart, and just focus on your studies. And believe me, the world on the other side is better than the world you are currently living in. I know the phase is tough, but that's how the life is. You will never get an easy life, but wish for a stronger you, right? So wish for a stronger you, wish for all the success that you aim for in your life. This is Dr. Shivam signing off. And do share the video and leave me a comment which will give me my part of happiness, right? Bye bye.